Welcome to Health in Today's Woman. I'm your host, Dr. Kelly Williams. This show was developed to help women become champions of their own health care. In the coming weeks, we will discuss, in layman's terms, topics and concerns related to women's health issues with my colleagues in the medical field. Together, we will provide you with the tools necessary to manage the jungle that has become the modern American healthcare system. Please note, every patient is different, and we are not your doctors. Please seek medical treatment from the physician of your choice. Today, we'll be joined by two well-known breast surgeons from the Murfreesboro Medical Clinic, Dr. Rebecca Baskin and Dr. Jimmy Carter.
A couple of weeks ago, while I was taking a shower, I noticed a lump. Who do I see? A family practitioner, an OBGYN, or a specialist?
Welcome to the premiere episode of Health in Today's Woman. That is a great question. In my practice, we often see patients that present after finding a lump in their breast in the shower. This can be a very intimidating experience, and patients often want to know, where do I go from here? Well, we're very lucky today to have two well-known breast surgeons from the Murfreesboro Medical Clinic, Dr. Rebecca Baskin and Dr. Jimmy Carter. Rebecca, where does the patient go from here?
Well, the first thing to do as quickly as possible is to call their physician, and that can be any of those physicians that she mentioned. And originally, you just need to meet them and get the further workup that's needed. And that usually starts with a mammogram. And if someone is feeling something that's new, that usually starts with what is called a diagnostic mammogram, so that they can take all the films that are needed at that time. If she's over 30, if she's under 30, it will often start with an ultrasound. If that woman is over 30, then an ultrasound may be added to the mammogram to help them distinguish exactly what they're seeing, if anything, on the mammogram.
And can any of those physicians order that, or do they need to be going to a specialist to be able to get those tests ordered?
Any of those physicians can actually order that test. Depending on what their comfort level is, they may then, if something is found, or if they're concerned about something that they're feeling but there's nothing on any of the films, then they will often refer to a specialist, a general surgeon, or a breast surgeon at that point.
And Jimmy, one of the things that I think is important here is also, when they do get to the doctor, what kind of things do they need to mention to you as the patient to begin to kind of have an idea of making your job a little bit easier?
Well, I think any woman that initially reaches up and feels a lump in her breast, the most important thing is to go to the doctor, to the nurse practitioner, and initiate a workup, get something going. One of the things I've noticed over the many years in practice of breast disease is that women will become so fearful when they feel a lump that they'll try to push it back in their mind. They want to basically not hear that there's something in their breast from a doctor, because I think my experience has been that a woman initially, when she feels something in her breast, convinces herself that she has a cancer. Well, fortunately, 80% of new masses in the breast are not cancer. The other things, once she does get to the doctor or the nurse practitioner and the workup begins and she begins a dialogue with her doctor, it's very important to know about family history. Okay. It's very important to know whether or not she's had previous breast problems, particularly if she's had previous breast cancer or that kind of thing.
Go ahead, Rebecca.
I was going to say also, she might have noticed, depending on how long she takes to address it, has this changed in shape or size? A lot of things we see are actually due to benign issues that may be even fibrocystic, and if this changes in size and gets bigger before the menstrual cycle and smaller afterwards, that's actually very diagnostic in itself and is a good sign, and that's something important to know up front. And really encourage women to remember what he said about the majority of things, over 80% that we biopsy, are benign. So most of the time we can get that woman peace of mind and get it quickly if she will just go ahead and address the problem. And
one of the things I think is really important that you mentioned is discussion. You need to initiate discussion, and that's something that I think is really important that we communicate to women, is this is a discussion, that you really need to go in with this information, but you need to it's a give and take situation where you need to give the doctor information, but you also need to be a part of that discussion and feel like you are actually having something to say in the situation. Do y'all agree? Mm-hmm.
I certainly agree with that, and I think one of the things that we like to emphasize in our practice is a relationship between the doctor and the patient, or the nurse practitioner and the patient. I don't want to leave that important group of people out, but I think at the opening of this segment, you mentioned one of the problems with modern healthcare. One of the problems with modern healthcare is many of us now have electronics in our office, like computers, and what we would like to do is interface with the patient when the patient is in front of us, and not interface with the computer. If your healthcare provider is not listening to you, get to somebody who will listen to you and do what you've mentioned, which is a dialogue, a give and a take, and make sure that all the components of the history and the family history and the past history are part of that discussion, and not leaping over the practitioner's head because he or she's too busy at the computer console.
That is a great point, and I noticed that even in my own practice, that it's so important not to bring in stuff. And different doctors have different personalities, and believe me, there is no such thing as a great personality or the perfect one. Every doctor's different. One of the things that I do find in my own practice is I have a lot of patients that come in and say, Dr. Williams, you've told me how to find a lump and you've told me how to do it, but I got lumpy, bumpy breasts. How can those patients determine what's a lump that's concerning versus a lump that, I may not need to go to the doctor? Or is there such a scenario where they don't need to go to the doctor?
Well, I think for the most part, there are a lot of women that have lumpy, bumpy breasts, and that goes along with something we talked about earlier, which is fibrocystic. But I think if a woman is comfortable doing her breast exam and can do her breast exam, she's going to notice when there is a new lump, especially a lump that doesn't go away after a month or two of her menstrual cycles. That is absolutely something that needs to be addressed. It needs to be worked up radiologically. It needs to be palpated by a physician or a medical expert, and then worked forward. Does that need a biopsy or not need a biopsy? So oftentimes women will find their own new lumps. There are some women that are so lumpy and bumpy and they get very scared doing their exams. Then they need to get a good working relationship with their physician and let their phizician do those exams, whether that's once a year or twice a year, whatever makes her comfortable, to make sure that something doesn't get missed.
I would add to that, in line with what you mentioned about how can they differentiate or tell the difference between a good lump, or a quote-unquote good lump, and a bad lump. That's really something that I wouldn't want the patient to be fearful about or worry about. As a matter of fact, I wouldn't want the primary care physician to worry about that. I want the differentiation, or the ability to tell whether a lump is good or bad, to fall under the care that I would render. Right. Because over the years, to tell the difference between a good lump and a bad lump is a very difficult thing, and I wouldn't want the patient to take the burden of that, nor would I want the primary care physician to take the burden of that.
We have had some great discussion, but we need to take a break here. When we come back, we'll be visiting the Murfreesboro Medical Clinic's Comprehensive Breast Center at their new facility in Murfreesboro, Tennessee.
Mammography. I hear it hurts.
Welcome back to Health in Today's Woman. To better answer this question, we took a trip to the Comprehensive Breast Center at the new facility for the Murfreesboro Medical Clinic. Today we'll be joined by Dr. Rebecca Baskin, who will help educate us on the tools used to diagnose and treat breast disease. We want to thank Dr. Baskin for being here today. This is a mammogram machine. This is one way to evaluate the breast. Dr. Baskin will now explain how this procedure is done.
As the young lady we talked to before had something that she had found concerning her breast, or her physician may have found something concerning her breast, the next step for those ladies that are over 30 are actually to have a mammogram, and this is one of those such machines. In this machine, the lady will be standing. They will place her breast here in the machine and put some mild compression. Then an x-ray beam is actually shot through the breast, and then a film captures the image, and that picture is read by the radiologist. I know that the lady did have a question, and many ladies are concerned about, does this hurt? And it's really about having an open communication with your technologist. They're very attuned to some of the fear or worry that ladies have, and once you talk with them and let them know if you ever have any discomfort or you're reaching to the point where the compression is just enough, then tell your technologist and she will stop at that point and take the film.
One of the things that you mentioned, which is very important, is they create an x-ray. Next, we're going to go look and see what that x-ray looks like. In our last segment, we discussed the fact that the mammogram machine creates an x-ray image. Now we're back with Dr. Baskin, who explained those x-ray images to us.
This is an example of a normal mammogram. When the views are taken, this is a side view as the breast is compressed from side to side. And this is a CC view, or as the breast is compressed from top to bottom. If something is seen in one view, it is then looked at in the separate view, and if it is in both views, it is considered to be a real entity and therefore must be further examined. As you can see on here, we're looking at chest wall and then breast, and here mostly just breast is seen all the way back to the chest wall. On this mammogram, these are an example of an abnormal mammogram. Here it's fairly subtle, but you see this wider area here in the center that has irregular or spiculated edges here and here. So now we've seen it in two views, and it even has a little white speck in it or calcium in it. This is considered suspicious and will need further evaluation and most likely a biopsy. This is another example of an abnormal mammogram. You see this triangular mark. This is put here because this lady was feeling something in her breast, and this is a picture of it on mammogram in two views. Because it is very regular and rounded, we're not sure quite what this is. It could be cyst or solid, it could be concerning or not concerning, and therefore would usually require further workup, usually with ultrasound.
Some women will require biopsy to determine whether the mass is cancerous or non-cancerous. Dr. Baskin, can you explain to us a little bit about how this table relates to women in the diagnosis and treatment of breast disease?
Yes. This is called a stereotactic table, and this is one of the ways that we have to do minimally invasive biopsies. This is for those calcifications or masses that show up on mammogram in two views. Minimally invasive means that the lady can have this procedure done as an outpatient in a short amount of time with a very tiny incision, lots of local numbing medicine, a little bit of anti-anxiety medicine, and be able to have this done here as an outpatient. Now, the lady will lay on this table face down, basically actually looking off toward the side with her breasts hanging down through this hole in the table. And this paddle is part of what it's held in compression against. Then this arm takes x-rays just like we saw in a mammogram machine, and these films are filtered through the computer, and the computer helps guide my needle through the very tiny incision to the right place in the breast to take little slices of the breast tissue so that we can get a very accurate diagnosis.
Some women are candidates for additional testing. One of those tests is the breast MRI. Dr. Baskin, can you explain to us a little bit how the breast MRI works and who's a good candidate for it?
Sure. Now, breast MRIs are not for the general public or every woman. It is not a good screening test. The mammogram is still for that. But breast MRI is used for those ladies that are considered higher risk or very difficult to get good mammogram films. Those high-risk ladies oftentimes are ladies that have already had a breast cancer diagnosed or treated, those who have had radiation to the breast, implants, or those ladies that are relatives of first-degree relatives that have breast cancer, and those would include mother, sister, or daughter, especially those under the age of 50. The MRI actually takes a very different view of the breast and actually shows not just the anatomy, but blood flow going in and out of the breast. And that's what makes a lesion in the breast look suspicious or not. Here, the lady lays here. This is the head or the face cradle. The breasts drop through here, so both breasts are MRI'd at the same time, and the legs would go in this direction. And as you can tell, this is a very nice table. This is, I believe, the only one here in Middle Tennessee that is used has all the extra padding and is an entire table just specifically for this test, for a breast MRI.
After the break, we will again be joined by Dr. Carter and Dr. Baskin in the studio, where we will continue to discuss breast disease. Welcome back to Health of Today's Woman. We are very lucky today to be joined by two well-known breast surgeons from the Murfreesboro Medical Clinic, Dr. Rebecca Baskin and Dr. Jimmy Carter. We've been discussing breast disease. In our last segment, you will notice that Dr. Baskin talked a lot about the mammogram, what was involved. We also talked about MRI. And one of the things that I want to focus on now, we talked a little bit about something called a stereotactic biopsy. So I want to talk a little bit about biopsy and the information we get from it and who needs it. So Rebecca, that's my question to you is, who actually needs a biopsy?
Well, we talked about basically anyone that notices anything new needs further workup. And if something is new to touch that is concerning, shows up new on mammograms, such as we showed the mass or calcifications, or something that's solid or causes distortion on ultrasound or suspicious on MRI, all of those are then going to be biopsied. The good thing is that nowadays we're able to do those with minimally invasive techniques, and that means with a little bit of medicine to take down anxiety, lots of numbing medicine done very slowly and very gently, and a very tiny incision, and can very quickly, sometimes the same day, get you a biopsy result back to allay those fears. Because as we mentioned, greater than 80% of the time that's going to come back something benign, and then that patient will never have to go to the OR or the operating room and have an anesthetic and have a large incision on her breast to get that answer.
Well, it's amazing the extent that we've gotten to in breast disease to be able to control these things and no longer have to do open biopsies. Jimmy, what about the patients you mentioned a little bit about minimally invasive. Is there anybody who needs to go for an open biopsy in the operating room anymore?
When I started practice almost 20 years ago, most of our biopsies were done open. Today and throughout the course of the last 10 to 15 years, we've been able to detect images of things inside the breast with ultrasound, with mammography, and with MRI. So if we can see some kind of lump or mass or calcium deposits within a breast with some kind of imaging guidance, ultrasound, mammogram, or MRI, we can get to that area of the breast that's of concern and take a biopsy with a needle. We have several different high-tech needle devices to get to these lesions. However, if a woman presents with a mass in her breast that doesn't show up on any imaging study like mammogram, ultrasound, or MRI, then we are left with the old gold standard of surgical open biopsy. There was a report recently in the lay press that 80% of biopsies in the country are still done with the open technique. In our practice, and I think the practice around Metro Nashville, most practices are done, breast biopsies are done through the skin with a tiny nick with a high-tech needle and some kind of image guidance.
That's amazing, and that's something that's really important to communicate to patients, I think, is this whole idea that you don't have to go to the operating room anymore, and it doesn't need to be a scary experience. Now, one of the questions I do want to move this to is when they get this biopsy back, you know, if it's benign or non-cancerous, where does the patient go from there?
Well, certainly a biopsy, much like the way we get to breast masses today, is very high-tech. It's based on image guidance and very high-tech needles. The pathology report is also complex. And I think there may be an idea out in the community that, well, it's either good or it's bad, either it's cancer or it's not. The problem is we now know over the course of many years of research that certain benign biopsies or biopsies that are not cancer have certain little changes or little nuances under the microscope when they're looked at that suggest that this particular patient may be at an increased risk in their lifetime for developing breast cancer.
And so one of the most important things I think I hear you say is that you communicate with your doctor about what they did find and not just take that it's just a benign or a cancer, but you understand what they said was benign. And even, you know, as I tell my patients oftentimes, write it down so that in the future when you're meeting somebody else, you can communicate this is actually what they found.
Because people do move and change physicians, and you want to know truly what your diagnosis is so that you may change, your physician may change your screening practices based on if that biopsy said that you're a little bit higher risk than your peers or if you're at the same risk as your peers, and you want to be educated on that yourself.
Well, we are very lucky to have had Dr. Baskin and Dr. Carter with us today. This is a great topic. It is one that lays a lot of fears in women about breast cancer, and that is a scary experience. In our next episode, we're going to deal with a different topic. We're going to deal with the topic that women of age will eventually run into, and that is menopause. We will be joined by Dr. David McKnight, a GYN at the Murfreesboro Medical Clinic, and Dr. Cindy Smith, a pharmacist at Reeves Sane Compounding Pharmacy in Murfreesboro, Tennessee, to understand bioidentical hormones, symptoms of menopause, and some of the parts of menopause that are important. Please realize that for diagnosis or treatment, you need to see your own physician. For encore presentations of this show, please go to newschannel5plus.com.
From the News Channel 5 Network, this is Health and Today's Woman with your host, Dr. Kelly Williams. Sponsored by Murfreesboro Medical Clinic.
Welcome to Health and Today's Woman. I'm your host, Dr. Kelly Williams. This show was developed to help women become champions of their own health care. In the coming weeks, we will discuss, in layman's terms, topics and concerns related to women's health issues with my colleagues in the medical field. Together, we will provide you with the tools necessary to manage the jungle that has become the modern American healthcare system. Please note, every patient is different, and we are not your doctors. Please seek medical treatment from the physician of your choice. Welcome to Health in Today's Woman. Today we're going to discuss a topic that all women will eventually face as they age, and that is the idea of menopause. Today we are very blessed to have two people to discuss this change with us. One is Dr. David McKnight, who is a GYN at the Murfreesboro Medical Clinic. The second one is Dr. Cindy Smith, who is head of the Bioidentical hormone program at Reeves Sane Pharmacy in Murfreesboro, Tennessee. But before we get started, I want to talk to you a little bit about what menopause is. Everybody goes through it, all women go through it. Many people don't really understand it. So I'm going to give you just kind of a real basic understanding of menopause, and then we'll start talking about the signs, symptoms, and other things that are involved. Initially, I want to talk to you about when you go to the doctor, they're going to talk to you about several tests. One is something called follicle-stimulating hormone, or you can think of it as egg-producing hormone. The second one that they're going to probably draw is something called estradiol. Now, the importance of these tests comes in the fact that we believe that you are born with a certain number of eggs. Every month, you'll lose an egg on your cycle. When those eggs are gone, there's no more estrogen. Now, follicle-stimulating hormone is a hormone produced by the brain to cause the egg to become produced by the ovary. When the egg grows, it produces estrogen. Estrogen is what prevents all the things we think about as far as signs and symptoms of menopause, including vaginal dryness, mood swings, and other symptoms we associate with menopause. Now, Some patients will have something we call perimenopause. But one of the other effects of estrogen is thickening the lining of the uterus. What happens as we get older is those eggs also get older. The estrogen doesn't function as well, and the lining of the uterus isn't as stable as it once was. That's what causes that breakthrough bleeding, or that bleeding between periods that you may occur as you get towards menopause. Now, to have a better understanding of menopause and some of its symptoms, we're going to now be joined by Dr. David McKnight, and we will begin to start discussing some of the symptoms that are involved in menopause. David, what are some of the symptoms that you see patients presenting to your office about menopause?
Of course, the classic symptoms are hot flashes and night sweats. With that, often there's sleep disturbances. People complain of insomnia, waking up a lot at night, mood swings, irritability, maybe mild depression. You mentioned menstrual irregularity, and that can manifest itself in the form of long absences of the period, where the flow comes every few months, or maybe even skips several months at a time. Or you can see a pattern where you're having bleeding every 2 or 3 weeks, more often than you were accustomed to.
Now, do all patients have symptoms?
No. For some women, the passage into menopause is a relatively smooth transition. They have very little in the way of symptoms. Their periods just kind of gradually stop, and it's all pretty easy.
Well, now, if my mom, for example, didn't go through menopause, very difficult, and had no problems, does that mean my daughters would also have that same opportunity to not go through menopause as difficult as others?
There's some evidence to suggest that, but not necessarily.
That's something that everybody wants to know.
Yeah.
What about, my patients always ask me, how long are these symptoms going to last? Because, everybody wants to kind of get to that point where the symptoms are going to go away. How long does the average woman have menopausal symptoms?
Well, the average age of menopause is somewhere around 51 to 52 years of age nowadays, and some will begin having symptoms well in advance of that. And some are through it relatively quickly, and others will have symptoms that will drag on for several years. I would say most women are pretty much through the rough part by the time they're in their late 50s. But I have some patients who continue to have the hot flashes and night sweats until well into their 60s or later.
And I know every woman out there is hoping that's not them.
That's right.
That's what every woman says to me. Now, we talked a little bit earlier about testing. What are some of the tests that you run when the patient presents to your office saying, I have hot flashes or vaginal dryness or mood swings or these things that are involved? What are some of the tests that you tend to order?
Well, I guess my big three would be to test their FSH level and their estradiol level. And then I'll usually check their thyroid at the same time, because high or low thyroid can also produce some symptoms that can be confused with menopausal symptoms. Usually what I'm looking for is that as you approach menopause, it takes a higher level of FSH to maintain a normal estradiol level. Eventually, once you become menopausal, then even that high FSH level still does not bring the estradiol level up into the normal range.
And remember, we talked a little bit earlier about FSH. FSH is a hormone produced by the brain that causes the ovary to produce an egg. When the egg is being produced, it produces estrogen, and estrogen is what the body uses to prevent those symptoms we talk about, the night sweats, the hot flashes, the mood swings. So that's what we're talking about. And then estradiol is just another way of saying estrogen. So a lot of women don't really understand those terms, and that's what they're kind of getting at. Right. And it's interesting that you say the FSH level will be high. So if your doctor calls you and says your follicle stimulating hormone, your FSH level is high, that means you're probably menopausal or working your way in that direction.
That's correct.
And thyroid is another one. Now, a lot of women are dealing with thyroid issues today. Mm-hmm. What typically do you see? Do you see a lot of patients with thyroid that manifest with symptoms very much like menopause?
Well, you can see menstrual irregularity with both high and low thyroid levels. You're not going to really see hot flashes, night sweats with low thyroid, but sometimes if you're really hyperthyroid or high, you may have some symptoms like nervousness and irritability and sweating that can be confused with menopause.
Now, when we return from the break, we've been very lucky to have Dr. David McKnight. We're going to take a visit to Reeves Sane Compounding Pharmacy in Murfreesboro, Tennessee, to learn about a new topic that's hot in the media right now. That's bioidentical hormones. When we get back from there, then we'll be joined by Dr. Smith to discuss more about bioidentical hormones. Welcome back to Health in Today's Woman. I'm your host, Dr. Kelly Williams. Today we're discussing menopause. In our next segment, we want to discuss a hot topic in the media today, bioidentical hormones. In order to better understand these compounds, we visited the compounding pharmacy at Reeves Sane in Murfreesboro, Tennessee. We are now in the compounding pharmacy at Reeves Sane in Murfreesboro, Tennessee. You will notice they use FDA-approved components in their compounds. You will also notice they have barcodes to provide extra safety. They take these compounds and mix them together in these mixing bowls in order to create the final prescription compound. You will now notice what is received as your final prescription, both in the pill form and in the gel and lotion form. We will now be joined by Dr. Cindy Smith. She is the director of the Bioidentical Hormone Program at Reeves Sane in Murfreesboro, Tennessee. She is also a professor at the University of Tennessee in their School of Pharmacy. Thank you for joining us.
Thank you for having me.
One of the questions that I think a lot of patients want to know is, what do we mean by bioidentical hormones? This seems to be a real hot topic in the media today, which I don't think a lot of people really understand what we're talking about.
Bioidentical hormones are actually plant-derived. They're all natural. Not everything that's natural, though, is considered bioidentical. Bioidentical is the closest match to your own hormones that your body would make. What we're trying to do is kind of fool the body into thinking, I made this, to make it look as natural as possible.
Now, what are some of the hormones that y'all are using in your bioidentical hormones, or just in hormone replacement therapy in general?
Really, the biggest hormones that we use are progesterone, testosterone, several different estrogens, mainly two estrogens, estradiol and estriol, and DHEA.
Now, does everybody get all those hormones?
No.
Or how do y'all determine what they do get?
It's very important to get a baseline to understand what the patient does need. And we do saliva testing, which is a little bit different from traditional blood testing. Saliva testing, the main difference is that with blood testing, hormones are generally bound to little carrier proteins that are like taxis that carry the hormones around. And saliva testing measures the free portion of the hormone so that we can get what we feel like is a more accurate measurement of where the hormone level is.
Now, one of the things you mentioned is saliva testing. When we were at Reeves Sane, one of the things that we were able to get was some video of the actual kit that y'all use in saliva testing. Can you explain to me a little bit of how this kit works and the way that y'all do it?
We actually work with a lab in Oregon called ZRT Lab, and the patient actually takes the test home. We explain to them how to do it, but they actually take it home and do it at home. Really the best time to measure hormones is in the morning. Thyroid hormones as well as sex hormones are usually released at the highest levels in the morning. So we have the patient test first thing in the morning before they have anything to eat or drink or brush their teeth.
Now, one of the other things I think is very important about bioidentical hormones, or just hormones in general, and being a gynecologist, I understand that everything's got its risks and its benefits. What are some of the risks associated with bioidentical hormones?
Well, bioidentical, as we said before, we're really trying to match the body's hormones as closely as possible. But estrogen in particular is associated with cell growth. That's its function. It stimulates cell growth. And cancer, breast cancer, is cell growth out of control. So anytime you're using estrogen, you are going to have risks that are associated with overstimulating cell growth.
Now, one of the other questions is, what about some of the positives? Because I think there's two sides to every story. And one of the things that we want to try and communicate in this show is that there are two sides to every story. What are some of the positives that we see in using these bioidentical hormones?
Well, we have been treating women for about 6 years now and treated about 3,000 patients over the years and have really seen patients to have their sleep disturbances relieved and anxiety and nervousness and things like that, that in a lot of cases we really don't have to use estrogen. We focus more on using the hormone progesterone to relieve those symptoms, which is a little bit different than what you would find in mainstream medicine. But we've seen a lot of patients to have a good deal of symptom relief without having to use estrogen or using very low doses of estrogen.
Now, one of the things I did catch on that you use is testosterone, and that's kind of interesting because a lot of people think, well, that's a male hormone, but y'all are using it in women. Who is a good candidate to get testosterone?
Well, again, we always want to get a baseline measurement to determine what the patient does need, and some women are given testosterone for a low sexual drive, but we always want to know what is their testosterone level on the front end, because if they have a low testosterone level, we want to supplement testosterone. That will help them with their sexual drive as well as memory, fatigue, and also with their bone health. If they don't have a low testosterone level and we supplement with testosterone, that would increase their risk of side effects, which would generally be facial hair, acne, those types of things which are undesirable.
And one other thing I think is really important, and one of the things in our community, in the OBGYN community that we discuss, is this whole idea of compounding pharmacies, and I know Reeves Saint is one of them. Can you kind of give us a little bit of information, kind of in a very brief story, about how to find a good compounding pharmacy? Because what we're talking about, these bioidenticals, are actually made at the pharmacy itself. So how can you tell a good one versus one that maybe I'm not so comfortable with?
Well, most of your really good compounding pharmacies are going to be associated with Professional Compounding Centers of America, which is PCCA, and they're out of Houston, Texas. And that's just a way of making sure that the standard of chemicals that we're starting with are of a very high standard. So a good compounding pharmacy would generally be a PCCA pharmacy. And there isn't a nationwide accrediting body as of yet. There is kind of a movement to get that started, but I would say if I was a patient, I would call that pharmacy and ask, how long have you been compounding? How many compounds do you do a day? And make sure that they've been doing it for a while, and that's a significant part of their business. It's not just something that they do a little bit on the side. That's where you're going to get more expertise. We
have had some great conversation. I really want to thank you, Cindy, because I think this is a great way to learn new things. When we get back from the break, we're going to be joined again by Dr. McKnight, and we're going to discuss the more traditional versus the bioidentical hormone therapies. We'll see you after the break. Welcome back to Health in Today's Woman. Today we're discussing a topic that all women will face as they age. That topic is menopause. In our first two segments, we discussed the signs and symptoms of menopause. In our second segment, we discussed a really hot topic in the media today, bioidentical hormones. Well, what I've done is I've brought both our guests together so we can further evaluate this idea of menopause and the treatments. Thank you all for joining us. And one of the things I want to talk to you about, Dr. Smith, is what are some of the treatments that we use for menopause? Not just the bioidenticals, but what are some of the treatments we use in general?
Well, mainstream treatment for menopausal symptoms usually involves estrogen. There are different estrogens available. Most of them are estradiol. Esterase is one. Premarin is another. Some women are actually prescribed testosterone. Usually that's something that would be compounded. But the general treatments are going to be estrogen-based or estrogen plus a progestin.
And David, you may be able to answer this too. Who needs the estrogen plus the progesterone?
If the patient still has a uterus, they need the progestin to prevent cancer of the uterine lining.
Okay. As I tell my patients often, Premarin was the greatest thing since sliced bread when it came out in the 60s. The only problem was when they gave it to women with uteruses, they ended up with endometrial cancer or cancer of the uterus, which is why we now add a second hormone, Premarin plus Provera or progesterone, anybody that still has a uterus. There's some new stuff coming out, though. We're starting to see not just the standard pills that we used to see. Now we're starting to see some other compounds like gels. What's the difference between the two, and is one better than another?
Well, there's some advantages to transdermal or through the skin administration in that the bulk of the estrogen does not pass through the liver immediately upon absorption. And so some potentially adverse effects on your metabolism are avoided that way. There may be less likelihood of complications like blood clots forming and effects on cholesterol and triglycerides and things like that.
Now, the big question, the one that you can't do a show on menopause and menopausal treatment without talking about breast cancer, because that's the one that everybody talks about. And I think it's a great question to ask both of y'all. Are hormone replacement therapies good? And do we need them? Or is this something that we're kind of playing with nature a little bit, playing with fire? What's y'all's opinion on that? Cindy?
Well, I would say that a lot of women have definitely been scared over the last few years. There have been several studies to show that there is some harm that can be done from hormone replacement therapy. But I would say that if you have symptoms, there is relief. Generally, what you want to do is to do a low dose, to do the safest method that you can, and do that for the least amount of time.
David, what do you have to say?
Well, what I try to tell my patients is that it's an individual decision that we make once a year. I think it's important to treat people as individuals, look at their particular risk factors, their needs, what their symptoms are, what the latest scientific research is, and try to come up with a plan that will best and safe and most safely meet their needs in the year ahead. And then we revisit the issue at checkup time next year.
And this is something I think is really important, because I hear both of y'all saying this, and we've said this in previous shows also. It's a discussion.
Yes.
And one of the things that we're really trying to do in this show is we're really trying to educate women so that when they do go to their doctors, we make healthcare a discussion, not just this is what you need to do. And I'm really excited to hear that this is what's going on in the medical community, because I think it is so important that there really is a discussion with patients. And something else that I kind of want to get onto is the idea of these herbal supplements. And both of y'all may have seen them, and I see them in my practice. Patients asking me about black cohosh or some of the other alternatives to taking estrogen or these. What do y'all feel about that? Cindy?
Well, those are what we call phytoestrogens, and they are plant-derived, just like we've talked about. Bioidenticals are plant-derived, but they're not what we would call bioidentical. Everything that's natural is not necessarily bioidentical. Usually, they're going to be your estrogen-type supplements, and I've definitely seen or had women tell me that they will relieve milder symptoms, but usually they don't relieve more serious symptoms for a longer period of time.
David, what do you find?
I would agree with what Cindy said. The relief from milder symptoms may be there. I don't think it's going to work well for the severe symptoms, and things like this really have not been studied so much scientifically that we can say that they're entirely safe. So I wouldn't take things like that, without discussing with your physician.
And one of the things, and we have just a few last seconds to in the show, but one of the things that we used to talk about was bone health, and one of the things that I know that a lot of women are worried about was estrogen and bone health. What do y'all feel about that? Because I know there's new stuff that's come out with the different medicines like Fosamax and other medications that are used for bone health. Do we still push estrogen as a positive for bone health, or are there other better options?
Well, I think hormone replacement is the most physiologic option, the best option. But for those women who can't use it or who have gone past the optimal time for usage, then the bisphosphonates like Fosamax, Actonel, Beniva are certainly useful tools. And Evista, which is a selective estrogen receptor modulator.
Mm-hmm. Well, we had a great discussion today. We want to say thank you to Dr. McKnight and Dr. Smith for coming in to really discuss an issue that's really a hot button topic in the media today, as well as a hot button topic to women who are getting older. The next show, we will be doing another issue that is very relevant to Middle Tennessee today, and that is skin cancer. We will be joined by Dr. Al Katine, a dermatologist at the Murfreesboro Medical Clinic, to begin to discuss some of the ideas about skin cancer and the things that we can do to prevent it and to treat it. Please consult your physician for anything that you see that you need to be diagnosed. Thank you, and we'll see you next week.